Good morning, and thank you so much for joining us in our training this morning. My name is Alicia Gonzalez. I am the Director of Clinical Training here at the Bridge Center, and I am very, very excited to welcome some friends that I will introduce briefly here to go over what I like to talk about as being the step beyond harm reduction, which is a much broader perspective on what harm reduction is, including the idea that maybe the ED in the acute care setting is the right spot to do some prevention work as well. If you are new to us at Bridge, you should know that we are funded publicly by the Department of Healthcare Services and that we work underneath the program, the Public Health Institute. We are a program of the Public Health Institute. So in that way, none of our speakers today have any financial disclosures. We do sometimes slip and say brand names, for example, like Narcan instead of naloxone. Please know that is not because we're funded by any pharmaceutical company. It's just because we slip into the words that our patients say sometimes, and it's not intentional. So I apologize if that happens. Most people who know about us at Bridge know about us as the substance use treatment people. And in case you're new to our bigger organization in general, what you need to know is that we were actually founded with this idea that our goal was to bridge emergency care and community health to create an integrated system that improves health and equity in a much broader context. And so, yes, that absolutely started with addiction care, but we now have other parts of our organization, including Access Bridge, which focuses on women's easier access to reproductive care, as well as what we call EDSP, which is our emergency department screening program, thinking about public health screening from the emergency department setting. And all of these programs, no matter which branch of Bridge we're talking about, is still going to emphasize the California Bridge model, which involves, number one, first and foremost, low barrier access to medication-based treatment for whether it's substance use or one of these other communicable diseases like HIV. We want patients to be able to get medication easily. We also emphasize the connection to care and community. We want our patients to have a smooth transition from us in the ED or the hospital into a clinic that can continue supporting them in the outpatient setting. And then finally, building this culture of harm reduction, which really is two things. One is trying to defeat the stigma that has surrounded some of these patient populations for a long time. But the other piece, honestly, is mitigating the risks of substance use and of some of these other things like HIV or hepatitis, whether it's because of drug use or any other reason. And so we want to help our patients do that. And now today, we're going to explore this idea that when we talk about a culture of harm reduction, it's actually harm reduction and prevention. Many emergency conditions could be mitigated or prevented if we were able to help our patients prevent that root cause altogether, which would include things like substance use, but really the picture is a lot bigger than that. And so our goal is to try to help make patient care simpler, more efficient, safer, and generally just more patient-centered. And why the ED? I mean, this is like the number one question that we're going to answer in general today in all these areas. But remember, we're not always thought about as a prevention focused branch of the healthcare system. But the reality is that a lot of patients do not have adequate access to outpatient clinic care for many reasons, whether it's insurance or actual access, transportation, et cetera. And so sometimes we're the only like hope or the only access point that our patients actually experience. So to dive a little bit more specifically into like why and how we might be able to help fill some of those gaps in a way that is actually efficient and fits within our care, I am so excited to introduce my three guests today. I will have each of them introduce themselves very briefly, but first let's start with Dr. Nicole Wojtal. Nicole.
Hi, I'm Nicole Wojtal. I'm an emergency and addiction medicine physician. I work in a busy emergency department in LA County, and I've been the bridge champion at my hospital since 2019.
Wonderful. Carolyn.
Hi, Carolyn Chu. I'm a family physician based out of San Francisco. I'm also here with my national clinician consultation hat on, which we'll hear about a little bit more later.
Wonderful. And Rebecca.
Hi, I'm Rebecca Nerenberg. I'm an emergency medicine physician and I work in New York. And I am also the clinical director of Access Bridge that Alicia mentioned earlier, and that I'm sure we will be talking about as we move forward.
Oh, we are definitely going to be talking about Access Bridge as we move forward. But so I want to maybe kick us off today by setting the framework for our conversation, which is that unfortunately, the word harm reduction, right? When we say harm reduction, I feel like it's a term that we hear a lot, but in some circles, it's kind of becoming this buzzword, right? Like there's like a weird angle people are taking about it, or they think it's a political word or a liberal word. We don't mean it that way. In reality, what we're talking about is literally what it says, reducing harm, specifically as it relates to medical harm that can come from medical issues or things like addiction or substance use, but also unwanted pregnancy, hepatitis C, HIV, right? Things that are preventable that can cause patients harm. And so, again, we're going to break that into two pieces, thinking about preventing those items, and then also how do we screen and treat our patients for these things when they actually have it. So for each topic that we cover today, I'm hoping that you all will be able to help me talk about both of those branches, the prevention and then the screening and the treatment, with an emphasis on how do we efficiently, as an emergency department centered group, how do we efficiently incorporate this stuff into our practice? So I think we should probably kick off with what we're most comfortable and most familiar talking about, which is substance use disorder. And Nicole, one of the reasons I invited you today is that you've really been doing this work for years. I mean, you're one of our like original Bridge champions at your hospital. And I know that we've made the argument over and over again at Bridge for why the emergency department should address substance use disorder care. Patients are already here. We're often their only access point. Medication saves lives. Like all of that is stuff that we talk about all the time. But I would love to know from the harm reduction side of things, how is that relevant to us as emergency clinicians?
Yeah, so a lot of times we focus on overdose death as it relates to substance use disorder, but there's many medical and social harms that are a direct result of substance use. So some of that you've already mentioned, infectious diseases like HIV, hepatitis C, there's skin and soft tissue infections like abscesses, cellulitis, endocarditis that occurs as a direct result of SUD. Both accidental and violent injuries often occur from substance use disorder. We've seen umpteen number of patients with presentations to the ER with mental health crises that are directly as a result of substance use disorder, as well as homelessness. So some of our patients, housing insecurity and homelessness is going to be preceded by substance use disorder. So there's numerous downstream effects of SUD that we need to consider in terms of harm reduction.
Yeah, and it sounds like, some of those cases really turn into very complex emergency care cases that are very time intensive or resource intensive. And if we can do things to prevent those or mitigate them or lessen that burden on our patient early, I mean, it sounds like a great idea. And I'm wondering if you could talk a little bit too about like the opioid side of things. When we think about the root causes of substance use disorder, do you think that there's still a role for us? Are we done addressing the opioid prescribing side of things, or are you noticing that that's still an area that we could improve?
Yeah, there's always room for improvement. So the better we employ harm reduction strategies as it relates to opioid use disorder and substance use disorder, the less of these downstream effects we're going to see. So the better harm reduction strategies that we can employ, we will impact our patients' rates of violent and nonviolent injuries. Will impact their rates of infectious disease, homelessness, potentially even mental health crises. So the things we can do in the ER include decreasing opioid prescriptions for pain. And I encourage everyone here, if you haven't seen the Alternatives to Opioid lecture, so expertly given by Alicia, please go watch it. It's a multidisciplinary approach to pain control with opioid sparing strategies for both mild to moderate acute on chronic pain. It's excellent. Additionally, having what can be tough conversations with patients about decreasing morbidity with respect to certain types of drug use, like IV drug use. So having a conversation, can you switch to smoking or snorting? And that relates to opioids as well as other forms of drug use like stimulants. Providing your patients with fentanyl test strips. This is wildly popular at my hospital. And if you need to get set up with fentanyl test strips, please contact Bridge and they can help you get set up with that. And fentanyl test strips are important for all sorts of types of drugs that our patients are using right now. Mm-hmm. Additionally, naloxone. So many of our patients don't fill their naloxone prescriptions either due to cost or stigma, or it's a schlep to get to the pharmacy and they don't have the ability to do so. But being able to provide naloxone to our patients and family is one of the greatest things that we can do as providers. Everyone loves leaving the ER with naloxone swag. Everybody. I love coming into the ER with seeing naloxone boxes strewn all over the place. The more naloxone out there in the community, the more lives you're going to save. It's super, super, super important. And lastly, patients and families like don't know what they don't know. So having signage in your waiting rooms, in your bathrooms about what programs are available or how they can actually get help in your hospital or clinic, super, super important. And again, Bridge can help with that as well.
Yeah, I love the visual of naloxone strewn about. Like I think about how when I go to the dentist, I get a free toothbrush at the end. And like honestly, I use that toothbrush. I change it out in my travel kit. Like, why aren't we getting people swag, on their way out? Kids get stickers, adults get naloxone. I sort of love that also. It's like an approach to a little gift. Like, thanks for coming. It's so silly, but people do enjoy it, and I I enjoy handing it out. So this might seem more like a straightforward question since we do talk about treatment for substance use all the time at Bridge, but maybe an odd question. Maybe you can like read my mind what I'm trying to get at here. But what are some pearls that you could offer clinicians when we think about the screening and treatment of substance use disorders, but through the lens of harm reduction? We often talk about it as like a way to save lives. Is there an argument to be made that medications for addiction are also always like a way to reduce the harms of addiction?
Oh, 100%. So if you take someone who's like a 10 times a day fentanyl user and are able to successfully switch them to buprenorphine, you are going to be reducing a lot of comorbid problems for them. So you will be doing harm reduction by treatment. And that's for any substance use disorder, whether it's OUD, naltrexone for alcohol use disorder, being able to offer medication for addiction treatment is harm reduction. And it can seem very daunting to have these kind of heavy, life-changing conversations in the emergency department and even framing them as a trial. We can try you on this drug. I'm going to send it to your pharmacy. It'll be there for you if you want it. Allowing patients to dose themselves. So for example, if you say, I'm going to write the prescription for 3 times a day of buprenorphine, start with 2, see how your symptoms feel. If you need to bump it up to 3, having this patient-centered approach, building trust, they're going to come back. They're going to come back for help. They're going to look to your ER or your hospital or whatever practice environment you're in as a place to go and get help. And ultimately, you're going to see those downstream effects for your patients in terms of preventing the kind of comorbid problems that we see as a result of SUD.
Yeah, I love your framing too, that I don't have to have a big life-changing conversation with somebody about entering sobriety and like treatment for the rest of their life, but that actually taking the lens of harm reduction, can I help you decrease your drinking? Can I help you, decrease your cravings for fentanyl? Do you want to try this medicine to treat your withdrawal? Is a much easier conversation for me. It's like a much shorter and more efficient way for me to get to the goal, which is the saving lives. And I think taking that burden away from me as an emergency doc is really helpful. I love that way of thinking, and then really like letting our patients have agency and knowing what their body needs and being able to have that agency that they often feel they have lost through their pathway in addiction. When I think about reducing the harms of patients who use drugs, I literally cannot help but go straight also into thinking about those communicable diseases that we often see in that setting, right? Things like HIV and Hep C. And so, Carolyn, I'm going to shift my attention to you for a second because now I'm thinking about things like sexually transmitted infections, GC chlamydia, of course, syphilis as well, but HIV, Hep C, et cetera. And what I've noticed as an emergency doc at multiple hospitals is that the practices and frankly, like the attitudes towards our role in those diseases varies so widely in regards to not only what everyone does as a practice, but like what tests I even have available, what's in my hospital versus what's a send out lab, what's the standard in regards to following up on those test results. And so I was wondering if you could first talk a little bit for us about, what is our EDSP program at Bridge? And then I want to dive into a little bit more of this, like, can I shake out what to do depending on your practice setting? So tell everybody first, in case they haven't heard of it, what is EDSP?
Yeah, no, thanks. This is, I think, just a hugely exciting partnership. So EDSP stands for ED Screening Program. And really what it, I think, is about is this incredible, innovative, I would say, partnership between the California Department of Public Health and Bridge, really kind of building on that hugely successful model that Bridge has demonstrated about building champions, building up sort of the community voices to really improve the health and safety of our communities. And so what EDSP is focused on is really expanding low barrier or opt-out screening and prevention for those communicable diseases that you just highlighted, syphilis, HIV, hepatitis C, but all through the ERs as a critical access point.
Amazing. We always hear from clinicians, and I, as an emergency doc, am always leery of this too, that we don't believe that we should be the answer to every problem in healthcare. And we shouldn't. I agree with that. So I'm very sensitive to that concept. And I'm wondering if you can explain why the ED. So we know this for substance use care because we talked about it so many times, but what about in this scenario? Why is the ED the right spot to be screening and thinking about starting treatment for these diseases?
Right. Yeah. I mean, I can definitely sort of feel that because I think in some ways we probably grapple with our same questions in primary care. And I would say, we kind of really need to shift the frame, shift the question. I mean, we're taking care of the whole person, right? Even if we're just, sort of with them in this moment of their life. And the whole person and their whole experience is often going to be more than, the substance use that might be a priority, but they are also living with loved ones, partners, you name it. And so they're going to have other exposures that can introduce things like HIV, gonorrhea, syphilis, you name it. And so that moment that they're seeing you in the ER is a moment to make change ultimately, right? And so you can make change through offering substance use treatment. You can also make change through offering screening and prevention for STIs. And so I think that is really sort of what is driving the concept behind EDSP. And then frankly, if we look at the numbers, the rates of STIs is just climbing high. And if I can just spend a moment kind of highlighting syphilis as an example. In 2023, so the CDC was able to put out their most updated surveillance data, we were seeing almost 2.5 million cases of syphilis, gonorrhea, chlamydia in the US. And that included almost 4,000 cases of congenital syphilis. So this is perinatally acquired syphilis. And that unfortunately also meant that there were hundreds of stillbirths and neonatal deaths. Syphilis is preventable. Syphilis is screenable. There are medications that we can use to treat and cure syphilis, which, is a real distinction between things like HIV that we don't yet have a cure for. And so people are coming to you in the ER. It's an opportune time to offer screening and treatment. And
Yeah.
frankly, even though we might be making headway in some things like gonorrhea, we are just really not where we ought to be with syphilis.
Yeah, that's an incredible number. Like it's like a staggering number. And I think one thing we often don't talk about enough is that a lot of patients who have syphilis, latent syphilis, or who have gonorrhea and chlamydia don't have to have symptoms, right? That
That's
they're out
correct.
there spreading these things, which increases really significant long-term consequences, right? Like, secondary and tertiary syphilis or pelvic inflammatory disease for females. There are lots of really bad outcomes that come from not knowing that you had an STI that's just been kind of residing in your body with no symptoms for a while. And then actually, didn't CDPH recently update their guidance on syphilis or something in response to those numbers?
They definitely did. And I think this is also a call out to folks here who are primarily staffing ER settings. So CDPH last year released an update. It really, I think, trying to, again, raise visibility about the importance of screening for syphilis. And so what the CDPH guidelines actually now say is that we ought to be offering screening to every pregnant person as soon as they are either sort of entering into pregnancy care, whether they are establishing that in the first, second, or third trimester. It doesn't really matter. It's just that first time that you're seeing them, for their pregnancy care. We also ought to be rescreening in the third trimester as early as possible, sort of around the 28-week gestation point, and then also at delivery. And so ERs might be seeing patients at any one or more than one of those time points. And really, again, that's highlighting the importance of ERs being able to be an access point for screening.
Yeah. So clearly we could and maybe should be doing more in this area. I'm wondering what, like, in my mind, the easiest thing is prevention, right? Like I think about the screening and the testing and the treatment, and I'm like, oh man, that's kind of time intensive. What efforts could we make to help prevent these things for our patients? I'm wondering if you can give me some tips, useful, efficient tips that I could use as an emergency clinician when I'm seeing patients, thinking about preventing who's high risk and how do I help them not get some of these items?
Right. Yeah. I mean, honestly, I think a lot of the things that Nicole had highlighted earlier, those interventions really sort of have the same role when we think about STI prevention. Some of it's really just opening up the conversation, helping to co-create that shared space with patients and community so that they know they can come to the ER if they have a question or a concern. Condoms, we hear a lot about, condoms, at least, depending on sort of where you are. I mean, ERs can certainly distribute condoms. You can prescribe condoms if you're a prescriber. And there are a lot of pharmacies in some communities that can just also sort of share that if someone feels comfortable going to a pharmacy and asking for condoms. Um, any of the counseling that we think about from a prevention standpoint. So again, many of these prevention interventions could work for some, not necessarily all of the STIs, but there are some that are vaccine preventable. HPV is one. I just saw an article today saying that we are nowhere near where we ought to be with HPV vaccine access. Even here in a high income country like the US, we are nowhere close to the 90% vaccine coverage that we want to aim for. And then for some STIs, namely HIV comes to mind, bacterial STIs, they're actually biomedical interventions. So prescriptions that we can offer to people in the ER setting to prevent acquisition of those STIs.
Awesome. And so I'm thinking now you're talking about like, the pep in pocket idea
Yes.
for, yeah, for things like HIV. I love that. And then, I also think that you were talking about when I was discussing with you prepping for this call, you talked a little bit about long-acting injectable PrEP options. I've never heard of that. Can you just tell everybody about what's coming down the pipeline? This is so exciting to me.
It is hugely exciting, and I think I'm also excited about the parallels that we're starting to draw sort of between the substance use world and then also the HIV prevention world, because there are some exciting things happening with long-acting injectable medications for substance use. So, long-acting injectable prevention meds are now available. The first one that was approved a couple years ago was long-acting cabotegravir. So that is given. There's an initiation phase, and then the maintenance doses are every 2 months. And then just last week, the FDA announced approval of the newest long-acting injectable prevention or lenacapavir. That is going to be a game changer because that is an even more potent medication that can be spaced out to every 6 months. There's going to be a lot of, I'm sure, negotiations around pricing and access, but I tell you that the HIV advocacy community is going strong to make sure that we have access to this new option for us, both in the US and then outside of the US and in global settings.
Yeah,
And this is
that's
going to be a game changer. There's no vaccine, but this lenacapavir is going to be a game changer.
Yeah, literally the idea that somebody doesn't have to take pills every day to prevent HIV is so exciting to me. And we will conquer the terrible insurance coverage, et cetera, like we do with naltrexone and buprenorphine and all the other medicines later. But I just love that science is coming down the pipeline.
Absolutely.
So I mentioned earlier that what screening and treatment looks like is so different at every hospital, at every clinic. So I'm wondering if you can give me a little bit of wisdom when it comes to some standards. Like if I'm a random ED doc, which I am at my hospital, how do I think about this? What's my approach to this? What are some maybe universal tips that you have for us?
Well, I mean, I think when it comes to just like how do I have the conversation or how do I place the orders, I think it can be as simple as you're here. Thank you so much for coming in. Would you like us to offer screening for STIs? If someone says yes, that's great. It's a urine test and a blood test. A lot of times now the tests are really bundled, so you can actually screen for gonorrhea and chlamydia just using sort of the same urine sample. In terms of HIV and syphilis, there it's drawing blood, and some ERs actually now might be interested in doing the point of care sort of rapid tests where if someone's going to be in your ER for 20, 30 minutes, they actually might be able to have their results in hand. You can sort of have the counseling before they leave the ER. And
So
so from
really
a
knowing
workflow,
what you have available
yeah,
in your hospital and being open to just saying if you identify any patient you want, but you could just say, by the way, while you're here, we're going to be doing some blood tests. Would you
yeah.
like us to also screen you for these items? If they say no, they say no. I mean, I love that as like not a mandate, but just sort of if you want to incorporate this into your practice. I love that so much. And then, I want to ask briefly, I think you could probably do a full day seminar on the treatment for each of these items, but do you have like a good place to point people if they want to know what's a good pathway for treating syphilis or Hep C, for example? I don't know a lot about treating Hep C. Like, what does that look like? How can I find that information if I'm interested in learning more about that?
So I think the EDSP group is going to be putting out some amazing, really comprehensive algorithms that are quite easy to follow and sort of will walk people through the different pathways depending on, again, sort of what the testing shows. Because someone might be positive for one, but not others, and it'll really sort of direct providers down the correct pathway. And so I would say watch that space. The EDSP group is going to put out some amazing clinical algorithms. And for some, the treatment will be straightforward, a shot, maybe a week's worth of prescriptions, and then linked to outpatient care. For chronic infections like HIV, ERs are going to be starting HIV treatment, linking to care. I think this is where the navigators are going to play a hugely important role, really just to sort of share the news, motivate patients, see what's going to work best for them after they leave the ER.
Yeah, and I just heard from my team actually privately, thank you for that update, that EDSP did put out their treatment protocols. I cannot wait to look at those literally as soon as this training gets over. So head to the Bridge website. The EDSP group has a handful of pathways there, which I love. And then I'll throw out as a personal thing that I love, again, no financial disclosures here, but the CDC has a free app for how to treat STDs that they keep up to date with the latest like which antibiotics, they adjust for resistance, that kind of thing. And so I offer that to as a free, publicly funded resource to anybody who's interested. I do love that one. And then I'll just toss this out there that, again, I had asked you when we were prepping about, if I really want to learn more about PrEP, for example, because I personally don't know anything about it. And I feel like that's like a big gap in my knowledge, and I want to do that for my patients. And you had mentioned that there's a really nice curriculum from University of Washington. So we'll drop that in the chat. If you're watching this later and you can't see the chat, you can just look for National HIV PrEP curriculum, again, from the University of Washington. That was a grant funded, really beautiful curriculum that they set up that was super helpful. And then let's make one more plug though, Carolyn. If I'm in the middle of a shift or a day and I'm like, gosh, I don't know what to do, who could I call? What could I do?
You could call our team. We could also just be that nice sort of human voice on the end of the line when you're just kind of tired and you need a screen break from your app or whatever, EHR you've been staring at all your shift. But honestly, like we're really as easy as like picking up and calling us. I like to say we were the original phone a friend before WhatsApp and signal groups and all that. But yeah, we're still here. We're still standing. We are federally funded. And so we are able to offer kind of real-time consultation for post-exposure prophylaxis for HIV, pre-exposure prophylaxis or PEP, Hep C treatment, HIV treatment, screening, diagnosis, any of the management questions, you name it. Call our team. We're here. What are we now? It's 6 to 5 Pacific. Those are our hours for our warm lines, and our 24/7 perinatal hotline is we're determined to keep it going as strong as we can with our funding.
That's awesome. And so the formal name for that, if you're trying to find it on your own, it's called the National Clinician Consultation Center from UCSF. So it's the nccc.ucsf.edu. Again, a free service out there, not just for California physicians, by the way. If you're on the clinical team anywhere, you can give them a call. In fact, probably for emergency physicians on the East Coast, those hours work better.
Okay, that's good to know.
Any time of their shift. But all right. In our final roughly 10 minutes, I want to shift to the third pillar. So we've done addiction care. We've talked about our EDSP, public health screening branch. Now I want to come into the Access Bridge section, our reproductive care angle. And Rebecca, obviously, I'm going to turn my attention to you as the clinical director for this program. I think it probably goes without saying that reproductive care is an area where it is very well known and documented that patients have difficulty with access to care, period, full stop. Doesn't matter which, we're not just talking about abortion, we're talking about contraception, et cetera. There's such a difficulty for women especially to access this care. And so I also want to honor that the current dynamic and political environment, if you will, is just making it even harder for women in certain states, in certain areas who, for example, do not want to be pregnant to not be pregnant. It's just making it harder for that to happen in multiple ways. And so being delicate and not making it political, but rather a patient-centered, low barrier to care conversation. Rebecca, I will ask you the same question that I asked Carolyn earlier, which is, can you start by making the case for me? Why is women's reproductive care an emergency department issue? Why is it something that we should care about in our work and worry about going forward?
Absolutely. So, as I know, Alicia, but the numbers are staggering. There are 19 million women in this country who live in what we call a contraceptive desert. And so that means that they live in a county where they do not have access to the full range of options for contraception. more than half of pregnancies in women under 30 are unintended, and actually 44% of all pregnancies are unintended. And obviously, you know, like many other issues that we run into and other things we've been discussing during this webinar, you know, the unintended pregnancies are increasingly becoming concentrated in populations of low-income women. You know, being pregnant carries a lot of health risks. And so being pregnant when you don't want to be pregnant adds a lot of other stressors and costs that you may not be interested in or have the ability to manage. And so, you know, it's very important. What we can do as clinicians is we can reduce the number of unwanted pregnancies, which actually then reduces both the need for abortion, but also reduces the need of other pregnancy emergencies like ectopic pregnancy and other complications that women have when they're pregnant. When women are able to have planned pregnancies, their pregnancies are healthier and it works better for them and for their families. And so in the ER, we see a lot of women of childbearing age. In fact, we see about half of women of childbearing age in the ER every year. And so we have an opportunity to address people who are able to become pregnant and their reproductive health care needs when we see them in the emergency department. So again, sort of very similar to the SUD stuff, the patients are already here, right? They may not be coming in for something specifically related to reproductive health care, but they're there in our ER. And so we do have this opportunity to try and help them prevent, you know, an unwanted pregnancy or other serious healthcare complications by asking them some really simple questions. And so it's really easy to ask a patient, do you plan on becoming pregnant in the next year? If they say yes, or they're thinking about it, great. We can give them prenatal vitamins to make sure that they have the best opportunity to have a healthy pregnancy. If they say no, we can offer them contraception or emergency contraception. And those are things we can do for them today, right now, while they're already in the emergency department. And, you know, there are some people who obviously are not sure what the next year is going to bring for them, and they're not sure what their plans are. And so we can, again, offer to prescribe them things that they can use as they see fit, that fits in their own life and their own life plan.
What I love about what you're saying is that it's really focused on the fact that number one, half, I want to emphasize that number because it's like staggering. Half of the women in our country who are able to get pregnant come to the ER every year. Half of them. Half of the women of childbearing age show up in the, I can guarantee you, I mean, I'm looking at you, Carolyn, but like probably primary care cannot say they're seeing half of the reproductive age women every year in the outpatient setting. That seems very unlikely to me, just like knowing the rates of in general, like preventative care. And so I'm thinking about even what you said, like if a woman wants to be pregnant, allowing her to get on prenatal vitamins, like think about preparing for pregnancy to optimize the health of mom and baby. Like this is a really patient-centered approach in general. And so I want to talk a bit more about the you want to get pregnant, here's some prenatal vitamins is an easy conversation. Let's talk a little bit more about the prevention side, because I'll be honest, I don't think that most ED clinicians are super well versed in the world of contraception. And I'll be really real that the only reason I am is because I am a woman, right? So like I've had to think about these things for myself before, but I wouldn't say that that was a thing I was trained to do. This certainly wasn't part of like my full spectrum of emergency training. So I'm wondering how I could incorporate that idea of starting women who want contraception on contraception into my workflow in the ED, but I don't want it to be a distractor for why they came, nor do I want it to be a big, suck on my time, or an awkward conversation with my patients. Like, I don't want to irritate. Are the women going to be like, why are you asking me this question? Like, can you talk about some of those items? Are they going to be annoyed with me? Like,
yeah, so I think, in the ER, we come in and we ask a million questions when we walk in the room, right? Why are you here? What symptoms are you having? We go through a whole review of systems. And so I think if you incorporate questions about, reproductive health care plans into your regular questions that you're already asking the patient, it just becomes part of what you're asking. And I think as long as you come to it with like an honest question attitude and no judgment about what the answer might be, then I don't think it annoys patients. And I think they just see it as another piece of what you're going over with them while they're in the emergency department. So I think it's pretty easy to throw in a question about, do you have any plans to become pregnant in the next year? And just to remind everybody, if somebody does not want to become pregnant in the next year and they are interested in contraception, contraception is legal in all 50 states. As you were talking about before, the political climate is changing and things are very different in different states. But still, to this day, as of right now, June 25th, 2025, contraception is legal in all 50 states. So offering contraception to a patient, talking to a patient about contraception, that is completely legal and within the bounds of medical care. You don't have to be an expert on every type of contraception that is out there, because there are, which is great for women, a lot of different types of contraception. So it's really good if you can just do a little bit of reading or a little bit of self-education and become familiar with a couple different kinds of contraception. One of the easiest ones to know about are the progestin-only pills, which are actually even available over the counter. And again, no financial disclosures, but just so people, in case they see, they're actually running ads, it's becoming more out there. There's one called O-Pill. That is a progestin-only pill that is available even over the counter. But again, we can also prescribe them to patients because sometimes that works better for their insurance. There are a lot of other, convenient options for patients. Some people prefer injectables like Depo-Provera. There are rings that are inserted vaginally. There are patches that can be changed weekly. So there are a lot of different options that can work for different patients with their needs. So on Access Bridge, we have a great quick start contraception care guide to use in the ED, which can help you and be a resource for you if this is something you want to start incorporating into your practice, but you might not feel as familiar with. And there's also a great educational resource called bedsider.org, which is very helpful. It's available in English and Spanish, and it's actually meant for patients to look at too. So we all know patients have a lot of waiting time when they're in the ED. They're looking for something to do. They need to pass the time. They're waiting for results or a CAT scan or a consult. And so this is something you can actually recommend to patients. Almost everyone, right, comes in these days with a phone. And so it's a great opportunity for them to educate themselves and do some reading while they're waiting. And that doesn't take up a lot of your time, right? Then you are free to go do other things while the patient is reading about contraception and educating themselves, while they're waiting for other things that are going on in the ED. Some practices do offer implantables or IUDs, which is great because it's a procedure, but that's not as common in emergency departments currently.
Yeah, I appreciate you saying that, I work in a small, rural, very busy emergency department where I don't know that the reality, is that I'm going to stop and place IUDs, but I definitely could prescribe a progestin-only pill, or I definitely could prescribe the ring. I mean, I ask women if they think they might be pregnant all the time anyway, because they have belly pain, they have whatever. I mean, it's actually, you're making me realize it's not that far off from the questions I'm already asking, and there are a million of them. So, um, you mentioned this earlier, and I'm wondering if you can talk a little bit more about this because I embarrassingly don't even know all that much about it. Can you talk about emergency contraception a little bit? Because I don't know that I've been talking about that with my patients enough, and it has the word emergency in it. I'm actually more more drawn to that concept. But tell me about how I should think about emergency contraception. What do I need to know to incorporate that into my harm reduction profile that I'm bringing to my patients?
Yeah, so I think emergency contraception is actually a really great uh, piece of harm reduction, because not if patients come, sometimes patients come in actually asking for this, they know about it. Other times in the course of your conversation with them, they may disclose to you that they recently had unprotected sex or are concerned about being pregnant and don't want to be. But it's also something that we can offer to patients that they can sort of, like you were talking about, pep in your pocket. Like it's something they can keep at home for themselves if they have a situation in which it could be helpful to them. So there's two main types of emergency contraception. There's Plan B and the generic levonorgestrel pills. And then there's another pill called ulipristal acetate, which is brand name known as Ella. And actually on our Access Bridge website, we also, in addition to having a contraceptive care start guide, we also have a guide for using emergency contraception that talks you through the difference between the two types of pills. And there are certain circumstances in which one may be better for a specific patient than another. And so that's a great resource to be able to look at. So again, you can offer it to a person who may be needing it acutely in the moment, but in somebody who, lets you know that they don't really have any plans on getting pregnant in the near future, it's also something you can just offer to prescribe to them that they can keep in their pocket to have when they encounter a situation where they may need it, which is really a great use of harm reduction.
Yeah, I'm taking away this concept of pill in the pocket from multiple of you as just get it out there and available at the pharmacy, ready for the patient. Bupe when they're ready for it. Prep if they need it. Doxy if they need it. Plan B or Ella emergency contraception if they need it. It's a really good idea to just sort of have that available to people. This has been amazing. I am shocked at how dense this was. There's a lot of information coming from each of you, and I want to just kind of say that it is unlikely that I, as an emergency clinician, am going to address everything that all of you just said with all of my high risk patients in the ER, right? That's that's just not realistic, especially in my busy shift. I'm like focusing on their actual complaint that they came here for. I personally, like, I'm a champion of this. I'm sold that I want to do some of this preventive work, but I also need it to be practical. And so I want to take a moment to ask each of you maybe for a final pro tip or a word of wisdom in our last couple minutes here that you would offer the average clinician. Like, when I think about this giant bucket of harm reduction and prevention and how it affects all of our patients, and I can't save the world in one shift, what is your word of wisdom? What is your pro tip? Nicole, let's start back with you.
Yeah, so in the Bridge Changemakers series, we emphasize starting with a current on the ground needs assessment of what is actually happening today in your group and starting there and thinking about how are you positioned within your group within the hospital in your community. And it might not be the right time to make massive changes within your group or massive changes for the hospital within the community. It might not be the hill you want to die on. It's okay to just make an individual level change if that's what you can do now. So it's important to think, what can I do now? What process can I smooth out now for myself or my group? And then later think about what kind of waves I can make in the hospital, the community at large. So Rebecca Trotsky, one of our implementation leaders, taught me a concept where she says, the right medication for the patient is the one they'll take. And similarly, like the right harm reduction approach for your patients in your community is the one you can do. So if the only person you can affect is yourself, start there, and then kind of work out from there. So again, do the ones you can do.
I love that what you're saying is not all of us are going to be able to build humongous like public health screening programs, but it's okay if like what you're doing is just saying to your patient, hey, do you want to be pregnant? You don't? Do you want to be on birth control? Like, if that's the only change you made, or you're just handing out naloxone, that like every step counts. Carolyn, what about you?
Yeah, I mean, I think in some ways that really rings true for our patients, right? So we're sort of being kind to ourselves, and I think it's also okay to be kind to our patients. And so we don't have to offer everything or sort of show all the A through Z menu, but it's okay to, I think, tailor it, right? Like as you get to know the patient, there may be, priorities that they are really wanting to focus on for that day, and then that's where you're gonna go. You're gonna sort of follow their lead. It's okay, I think, for us to hear no sometimes for our patients, and that's all right, as long as we have that open door and we're inviting them to come back in when they're thinking, okay, maybe, or all right, now it's yes. I think that that's important. And then honestly, I think, all the amazing work that everyone here is doing in the ERs, that's encouraging me as a primary care provider to do better. You know what I mean? That like that I draw from that strength and that championship that you all are showing. And I think we need to be forward looking right now. And so all this is really important for our entire system.
Yeah, what I hear you saying is that even building the trust by opening the conversation is in itself harm reduction. Because maybe they tell me no today, but they feel comfortable coming to me and asking in the future at their
Exactly.
next visit, bringing something up, which is a really beautiful take home point. All right, last but certainly not least, Rebecca, how about you?
Yeah, so I mean, sort of very similar to the other things that we've already discussed, starting with something that may be prevention or a project that may be a smaller project is really great because any change that you can make is better than not making any change, right? Any prevention you can offer your patient, any harm reduction you can offer your patient, it doesn't have to be all of it all at once, right? You can start with something smaller. Even if you do want to make a change within your hospital or your group or your department, maybe you start with a change that's not as big, and then people get comfortable with you and knowing that you can follow through and carry through a project. And so then when you try to make a bigger change, people are more open to that because they've seen you do this in the past. And just remember that doing a project that isn't your biggest project doesn't mean it's not useful, right? Any patient that you can prevent from being pregnant, you can prevent a lot of really, harmful healthcare complications down the road. And then just the other thing is to remember that you can, we're all in the ED, right? There's a lot of waiting time. And so let your patients do some of the work. Let them do some self-education, let them do some reading, give them something to do while they're waiting for their CAT scan or while they're waiting for their ultrasound results. And that way, when you come back to talk to them, they're already a few steps further down the road than they were when you first approached them.
Giving my patients homework while waiting is my new favorite idea that maybe came out of this. I have so many things that I might be doing that for. I want to say thank you to each of you for being here. And in my attempt to recap in 45 seconds, first of all, for anybody on this call, let us think about harm reduction as two things. Number one, prevention, and number two, screening and treatment. The harm reduction is a really big picture thing. It's not just naloxone, right? There's like so many things we can do to prevent chronic disease and then also screen and treat for those efficiently and when it's relevant in the emergency department. And for substance use disorder, we're very familiar with the rates and why the ED is, the right place for that, but you can prevent it by being intelligent with your pain control, right? Not using opioids when you don't need to, teaching patients how to manage their pain, not requiring prescription medications, and also addressing the root causes, thinking about how we got here. Is it, housing instability or food instability? What is it that's driving somebody to even use substances? And then thinking about, obviously, bupe for opioid use disorder, medications. They don't have to be ready to commit to a life of sobriety. We can just do a trial. We can use medication as harm reduction to help our patients enter that road to recovery at a way like low barrier, way more low barrier and less of a long-term commitment thing. It's just easier for all of us to get through that conversation. And of course, making naloxone askew everywhere across the entire ER, like the toothbrushes at the dentist. I love that. And then for our EDSP, angle, thinking about public screening, talking to patients about safe injection practices. If they're going to inject, can they switch to smoking from injecting drugs? Give everybody condoms who's having sex, like talking about, STDs and condoms. Thinking about the HPV vaccine. Is that even available in your ED? And if it's not, at least maybe broaching the subject with patients, or Rebecca's idea, give them a handout about it, talk to your doctor about this vaccine. And just to know all that stuff, thinking about having medication available, the PEP in the pocket. Do we want to treat empirically, knowing that syphilis rates are rising, telling patients that openly, they don't have to have symptoms. Can we do screening today? Especially in pregnant women, can really save lives and decrease morbidity and mortality. And maybe a giant public health screening program is not feasible at your hospital, but do you have a good referral process? Can you even talk to patients about it? Maybe just trying your local public health department can be a good place to start. Rome wasn't built in a day. You don't have to make your hospital the central public health screening hub, nor does every ED need to take that on, but you could talk about it. You could bring it up with your patients. And if you want those educational pathways, how to screen, how to treat, please head to that EDSP resources website at the Bridge website. And then finally, half of women of childbearing age are already coming to see us in the ED. So take that beat, ask them, do they want to be pregnant? And if they do, get them on prenatal vitamins, improve the odds that that neural tube is going to form well in that fetus that they're really trying to make. And if they don't want to be, can we help prevent it? The number one way to decrease abortions is to decrease unwanted pregnancies. And so take away the need for women to have yet another, medical encounter or another complication. There are lots of ways to learn about OCPs and other contraceptive methods. Please head to the Access Bridge website for that. It doesn't have to be complicated. You don't have to know every method. You can use that Bedsider or other apps to let patients do some of that reading while they're waiting, so you don't have to spend a ton of time, but it can be a life-saving and certainly a morbidity and mortality reducing measure to help women who don't want to be pregnant not be pregnant. And it's legal everywhere. And while this was a ton of information, the reality is no one expects you to do all of this for every single patient. So thinking about what is the one or two things that you can do in your practice for that patient, that time, for every patient, every time, but in a way that makes sense for them and that fits into your workflow. So we went over 1 million resources. We will send them out in a post-training email if you were here with us live, but if you weren't, you can head to the Bridge website. All of our resources are there for you and they're free. Please feel free to use that, to help guide your practice. And then if you want more accredited CME available to you for free, whether it's about substance use, etc., please head to the California Bridge Academy. We have one for nurses, one for clinicians, and one for navigators as well. So head there. It's always free for you, hosted by all of our wonderful Bridge team, including some of our panelists today. And then if you have any specific questions, you can't remember the phone number that we just mentioned, you want to know more about something, you want support starting one of these programs at your hospital, you can join us or email us directly at info@bridge2treatment.org. Thank you again to all of our panelists today. I cannot tell you how nice it is to have this much knowledge coming to me from such amazing people who are doing the work and so who know how it fits into the acute care setting. And I can trust all of your perspectives and I appreciate that. But I also want to thank all of you who are here with us doing this training, for taking the time to learn it, for being open to the conversation, and most importantly, as always, for everything that you are doing to help us reduce harm and save lives. Thanks, everybody.